for the next 30 odd minutes, I'll be taking you through the journey of conduction system pacing. We have learned the technique of conduction system pacing way back in 1970, when people have demonstrated that you can capture the so-called conduction system fibers with the help of temporary catheters. So we have moved a long way from 1970s. The first feasibility study was done in 2000, when Dr. Deshmukh showed that it is clinically possible to deploy the conventional leads directly over the his bundle. There are certain limitations which we often face with his bundle pacing. So ultimately now we have landed up in doing more frequently left bundle branch pacing. So like any scientific terminology, we need to understand the anatomy of the subject what we are dealing and the physiology of it. And then comes the other things, the implantation techniques and clinical skills. So I've divided my topic into three major sessions. The first one is about anatomy. So we need to know the anatomy of cardiac conduction system fibers if you want to do a clean conduction system pacing. Next, I'll talk a little bit about physiology, not a typical electrophysiology, it's about physiology. Then finally, I'll discuss about the implantation techniques. So feel free to stop me at any time. I may be a little fast, just I know some of my friends are there, they can hold me and stop me at any time if you want, right? So this is what the cardiac conduction system fibers. We have learned from our first year MBBS time that it starts from the SA node. It goes through three internodal pathways to reach the AV node. From there we have his bundle, and this his bundle divides into left bundle and right bundle. The left bundle has three divisions: anterior, posterior and septal fascicles. The right bundle will not have any further divisions. It goes as Purkinje fibers and innervates the ventricular myocardium. So any disease in the conduction system fiber will produce symptomatic bradyarrhythmia, and for that we have to do a permanent pacemaker implantation. We are doing it since 1950s, but we have learned that pacing the right ventricle, it's all myocardial pacing and not stimulating the cardiac conduction system fibers. So this pacing the right ventricle is going to produce deleterious effects on the left ventricle. How? We're going to activate the right ventricle non-physiologically. It's going to pull the septum first when the left ventricle is about to contract. When the left lateral wall contracts, the septum relaxes, and when the septum contracts, the lateral wall relaxes. So this synchronized activation will ultimately result in the so-called pacing-induced cardiomyopathy. So people have quickly moved to alternative sites. We learned that going from an apex to outflow tract or to the septum might help in preventing this cardiomyopathy, but the trials have shown the other way. So none of the studies have shown superiority of non-apical pacing to apical pacing in terms of reducing the complications. So ultimately, when they searched for alternative site, there came the conduction system pacing. So there are two important sites in the cardiac conduction system fibers where we can easily deploy the lead. One is the his bundle, the second one is the left bundle. So if you ask me which is the most superior form of physiological pacing, I would say his bundle, because his bundle rises just before the bifurcation. It's going to provide physiological activation for both left ventricle as well as right ventricle. So anatomically, the his bundle lies over the membranous septum. So you have learned from our anatomy that the membranous septum has two components divided by the tricuspid leaflet. The superior one divides the right atrium from the left ventricle. There we tend to have this turbo defect and all. And the inferior one divides the right ventricle from the left ventricle. So you have atrioventricular component and ventriculoventricular component in the membranous septum. The his bundle lies directly over it. So you have basically two components of his bundle. One is the atrial component and the second one is the ventricular component. So practically speaking, you can do his bundle pacing by deploying the lead still in the right atrium. But what are the disadvantages? So when you are deploying a lead for serving the ventricular purpose, it should not see what is happening in the atrium. So when you are going to deploy the lead in the atrial component of his bundle is going to oversense the atrial events, undersense the ventricular events, and the threshold may not be good. So it's always better to go below the tricuspid leaflet to capture the ventricular component. So you can easily identify the fat pad line. When you move to our right anterior oblique view, there will be a fat pad line which will tell you that the above component is atrium and the below component is ventricle.
But technically, implanting it in the right atrial section of the his bundle would get you out of jail in a patient with tricuspid valve replacement. So perhaps,
exactly.
or you can go into the CS to pace.
Yeah, exactly. So there are certain ways where we can negotiate the leads in patients with a tricuspid valve replacement, especially prosthetic valve. So one easier way is to go into the CS, and probably the tougher way is to get into his bundle in the atrial component. We have to see the long-term outcomes of doing the atrial component of the his bundle pacing. So the chance of lead dislodgements, rise in thresholds, all these issues are there. So we prefer to go in the ventricular component if feasible. Otherwise, these days we tend to go into the left bundle. So basically the his bundle fibers over the membranous component go into the crest of interventricular septum, where it divides into right bundle and left bundle. So obviously the right bundle means it will be on the right side of the interventricular septum, and left bundle means it will be on the left side of the interventricular septum. Histologically, so you need to know the histological importance of classifying the his bundle. There are three important varieties of his bundle. So one will have some sheets of muscle fibers. So you have to drill the lead little bit inside to capture the his bundle. So that is the most common type, what we call it as a normal his bundle, which is seen almost clearly 50% of the patient. In type 2, there will be thick muscle fibers, muscle sleeves. It's all membranous septum. And the his bundle will be deep seated. Here it will be very difficult to penetrate, and majority of the time you will end up in having a septal pacing or somewhat a non-selective pacing of the his bundle. This is not a good his bundle for doing his bundle pacing. The third one is a naked his bundle where nothing will be there. The his bundle will be exposed just to the endocardium. You can easily capture the his bundle, but at the same time, these are all the bundles which are notorious for iatrogenic injury. So many times when we are doing AV and RT ablations, even a simple catheter movement, we have seen the patient going into AV blocks. So even when you are putting a temporary catheter, when you are tip of that 6 French temporary catheter, if it's going to hit the tricuspid leaflet, you might have seen transient AV blocks occurring. That's all because almost like 20% of the patient can have this naked AV bundle, his bundle, where though the procedure is little easy, but the patient will be at risk of developing iatrogenic AV block. So this is what I was talking about, the atrioventricular component, membranous ventricular component. So if you want to do a good his bundle pacing, go below the tricuspid leaflet and target this aspect of the his bundle where you will get a good threshold, good R wave, and not much of atrial oversensing. So his bundle then divides into right bundle and left bundle. So this single picture will tell you why we prefer left bundle pacing over his bundle pacing. You can see his bundle, which is probably a thin card, and you can see how broad the left bundle fibers are. So this much broad left bundle fibers gives a wide target area for deploying the lead, but there you can see his bundle, which is probably 4 class 2 millimeter. The margin of error is very, very less. But here, this one, a broad fiber, so if you trace it down, still more it widens out on the left ventricular aspect of the interventricular septum. So the target area will be very, very huge so that we can easily do the procedure. So the left bundle further divides into anterior fascicle and posterior fascicle. You can capture anything, so the left bundle as it comes, goes anteriorly as anterior fascicle and comes down as a broad fan of posterior fascicle. So you can capture the left bundle at any site, whether in the main trunk, anterior fascicle or posterior fascicle. So let us go a little bit into the physiological aspect. I've given some special color markings for the fibers inside the his bundle. That means that the fibers inside the his bundle are longitudinally dissociated. All these fibers are predestined. That means that this yellow fiber will go only into the left bundle and this red fibers will go only into the right bundle. So if you have any segmental disease within the his bundle, so if it affects the red fibers, the patient can have a left bundle branch block or right bundle branch block depending upon the segments getting affected. So this will tell you that you can do his bundle pacing to correct the left bundle branch block or right bundle branch block, right? So it is all happening within the his bundle itself. LBBP doesn't mean that the disease is within the his left bundle only, and RBBP doesn't mean that the disease is in the right bundle. Majority of the patient will have disease within the his bundle. So all we have to do is identify the disease site and go little distally to capture the disease-free segment of the his bundle. So this anatomy and physiology of his bundle is very, very important when you want to do his bundle pacing. But left bundle branch pacing is a little bit easy because almost 95% of conduction system disease occurs within the his bundle. So your proximal left bundle is free, disease free, it's easy for access, and the target area is very wide. The only difficulty is how to take the lead from the right side of the septum to reach the LV subendocardium. So that is probably a easy one to learn. The learning skills are quite easy. The curve is quite easy. When you do probably 10-15 cases, you'll be able to do the procedure in a better way. So this is all about anatomy, and conduction system pacing involves some sort of electrophysiological skills as well. So I want all of you to know a little bit about electrophysiology, not a hardcore electrophysiology, a little bit about AV nodal conduction and his bundle conduction, what are these AH interval and HV interval, so that you can do a clean job for doing resynchronization therapy in heart failure patients. This is all about my first part. So if you have any doubt, probably you can ask, otherwise I'll move on to my second part of the lecture. Any doubt? Yeah, so that depends on how the fibers are oriented, and majority of the fascicular VTs usually comes from the microcircuit in the posterior fascicles, within the posterior fascicles, and the septal fascicle re-entries are very, very rare. So it comes more in terms of interfascicular VTs, that's very, very rare. So I'll just try to simplify this electrophysiological aspects of conduction system pacing. So this is how the impulse spreads. So it starts from the SA node that we have learned, and an EP procedure, we need to put multiple catheters at multiple sites. It's a very simple thing when you understand the concept. So we will be measuring the electrical impulse at 4 or 5 different sites and see which comes early. So you have to have one standard electrogram for comparison. So we will take either a surface ECG or some specific landmark like coronary sinus electrograms as a reference, and we will analyze the electrograms at the left atrium, right atrium, SVC, pulmonary veins. All these things will be compared with reference to a standard comparable electrogram and see which comes early. So this is how we study the activation pattern of an arrhythmia, and this will be color coded. So whichever comes early will be given a color of white. So it's very easy for us to see the color that where the white lies will be the site of earliest activation. So we'll just burn the arrhythmia. So it's a very simple concept of comparing the local activation with some standard reference landmark. So for that we need to put multiple catheters. So the common sites will be the right atrium, right ventricle, his bundle, and the coronary sinus. Coronary sinus being in the atrioventricular groove. It records both atrial and ventricular electrogram, and his bundle being right across the tricuspid leaflet, it measures atrial, ventricular as well as the his bundle electrogram. So we need to know two important views whenever you are doing pacemaker, be it a regular standard pacemaker or a conduction system pacing or even a biventricular pacing. The first and foremost is right anterior oblique view. This is the view which we always start doing the procedure, be it an EP procedure or a conduction system pacing. So this is how the components will be looking like. You can see the SVC coming down and the IVC coming up into the right atrium, and the ventricle will be like this. So we try to place a catheter in the right atrium, a catheter in the his bundle, and the catheter in the right ventricular apex. Basically, this coronary sinus catheter, it is easy for us to access through the internal jugular vein, so that it goes just quickly into the coronary sinus catheter, sinus vein. Basically, what we are going to learn from the RAO view, so we will learn where our catheter is in terms of the position within the right ventricle, whether we are closer to the tricuspid leaflet, whether we are closer to the apex, or whether we are in the right atrium, IVC component of the right atrium, SVC component of the right atrium. On the other hand, this LAO view will help us in identifying whether we are hitting the free wall or the interventricular septum. This is very, very important, because we know when you deploy the lead in the free wall, the patient will develop tamponade. Will not have good parameters. So your catheter should orient towards the septum when you want to do a septal pacing. That septal pacing can be a mid-septal pacing, apical septal pacing, outflow tract septal pacing. So anywhere if you want to do, your catheter should be facing towards this interventricular septum. The top one will be the interatrial septum, and the lower one will be the interventricular septum. So if you want to deploy the lead should go like this. On the other hand, if the lead is going the other way, anteriorly, that means that you are facing the free wall, and that will result in cardiac tamponade. You will not have good parameters as well. Luckily, we are doing conduction system pacing with a specially designed catheters, and these catheters will take you towards the septum only. So probably the safest way of doing a septal pacing will be the conduction system pacing. The sheath or lead cannot take you to the free wall. So the chance of developing tamponade due to free wall injury in conduction system pacing is close to zero. So that is the biggest advantage of using delivery catheters, because this has multiple curvatures to take the lead towards the interventricular septum. So just to summary, LAO view always used to compare the septal versus lateral catheter position, and it always helps us when you are doing an EP procedure to see where exactly on the tricuspid valve or where exactly on the mitral valve you are. But on the other hand, RAO helps us in identifying whether you are basally, apically, or in the outflow tract. Intracardiac recordings, this is probably the toughest for the beginners, but when you understand it with the anatomical correlation, it will be easy. The first catheter will be in the atrium. We know the atrial catheter will record the atrial electrogram. And the second catheter will be right across the tricuspid leaflet. Since it is across the tricuspid leaflet, it will record the atrial signal, his bundle potential, and the ventricular electrogram. And coronary sinus catheter, since we learned that it is in the AV groove, it picks up both atrial as well as the ventricular electrogram. And the right ventricle will record only the atrial electrogram. So out of this, we are going to choose the his bundle electrogram and the RV electrogram for understanding the physiology of conduction system pacing. Because we are targeting the his bundle, so we need to know where the his is. So you can get the his potential, these sort of electrograms, with the pacing lead itself. The pacing lead can be connected to the programmer to see this, or if you have an EP system, you can connect it and see. It's just a simple thing, just like putting a temporary pacing catheter. Put this temporary quadripolar catheter right across the tricuspid leaflet in right anterior oblique view, connected to the EP system.
Sir, she wanted to ask.
Yeah, please.
Sir, in the CS and the RV intracardiac the EGMs, the ventricular spike is differently timed. So why in the CS one it is a bit delayed, whereas in the RV apex it's...
Yeah, exactly. Good question. So this RV electrocatheter usually goes into the RV apex, and the right bundle, the course of the right bundle, if you have read, it courses towards the right ventricular apex, and it terminates over there. And in fact, the earliest signal, the earliest intracardiac signal in the right ventricle will be the right ventricular apex. A good question.
In fact, it is more slightly offset from the apex, from the third model.
Moderator.
To the right side.
Exactly.
To the left side, and the CS catheter will be deep into the...
Yeah, it will be in the lateral wall.
Posterior basal part of the LV.
Exactly. The
Minus
CS...
50 millisecond, I
Usually 30-40 milliseconds will be the difference. So the lateral valve will be the last valve to get activated, and it will be falling on the lateral part of the QRS. When you compare the duration of activation, the lateral valve activation will be somewhere around 40 milliseconds later than the earlier part.
RBBP, this RVA will be slightly later.
Exactly, because it comes from the left ventricle. Yeah, good. So his catheter will be right across the tricuspid leaflet. So this is the atrium, this is the ventricle. So if I've shown in that. So you can see this is the atrium, this is the ventricle, and this is right across this tricuspid. This is the tricuspid valve. So it is right across the tricuspid leaflet. So obviously it should record both atrial as well as the ventricular electrograms.
So, but what about the relative sizes of the atrial electrogram and ventricular electrogram?
Yeah, so that is.
People say that it should be equal if you are in his, but then
Yeah.
there are other people say that who say that the ventricular mass is more. So if it is equal, you are more to the atrial side rather than the ventricular side.
Yeah.
So validating that will be difficult. And plus, if you go slightly more distally, you start recording RBB potential rather than the ventricular potential.
Yeah, so exactly. So for that you need to know what are these intervals meant for. So there are basically two important intervals which we have to see. When you place the His catheter, I said there will be an atrial electrogram, there will be a His bundle electrogram, and third will be the ventricular electrogram. So you basically will be measuring the distance between these two electrograms. So between the A and H will give you the AH interval, and between the H and V will give you the HV interval. So what does that interval mean? So basically AH interval will tell you what is happening to the AV node, and this HV interval will tell you what is happening to the His bundle. So basically you can equate this AH interval to AV node disease and HV interval to a His bundle disease. So any disease in the AV node will prolong the AH interval. The upper limit of AH interval is 120 milliseconds. It varies between 55 to 120 milliseconds. And any disease pertaining to the His bundle and the below structures will prolong the HV interval to more than 55 milliseconds. The normal HV interval is 35 to 55 milliseconds. So as far as HV is concerned, we are very strict. Anything less than 35 is abnormal. So when it will happen? Shorter HV interval? Exactly. So pre-excitation, the HV interval very short because there will be a pre-exciting fibers which will pre-excite the left ventricle or right ventricle. And anything more than 55 also will not accept. We say it as an abnormal HV interval. So how is it going to help when it comes to conduction system pacing? Like I was telling, when you place the catheter right across the His bundle, you will be able to see this A, H and V. The more distal you are, the shorter will be the A wave, the better will be the V wave, and the tiny will be the potentials. So that's what all we want. We want to deploy the lead in the distalmost aspect of the His bundle so that you will get a good R wave, a very poor A wave which we don't want, and a good threshold. The more distal you go, there will be some part of membranous septum which will try to hold the lead as well. So that gives us enough safety in terms of lead threshold as well. In the future, even if the threshold rise, there will be some myocardial fibers which can capture. So it's better to have this sort of electrogram where you can see a very, very small A wave, very small A wave and a sharp H and a big V wave. So this is probably a good site for deploying the his bundle lead.
RBA V wave occurs even before the his V wave because the fibers get unsheathed more towards the RBA catheter rather than the his catheter.
Yeah, so that depends on the position of the catheter as well. So whether it is moving towards the septum or not, during procedure we will not know what makes the catheter to move. So this AHV measurement is very important. So this particular patient, you can see in the surface ECG that there are more number of A's as compared to V. You can see a lot of A's are going but V's are less. The same thing is happening in the intracardiac intervals also. A lot of A's are going but the V's, ventricular electrograms are less. But the most important thing which I want you to identify is not all the A's are followed by H. You can see the A's are not all the A's are followed by H, but the H is preceding every ventricular electrogram. That means that there is some problem between the A and H, but the H and V is normal. Exactly. So this is a form of AV nodal variety of complete heart block, and as you can rightly see in the surface ECG, the QRS complex is normal. It should be normal. So any disease pertaining to the his bundle will produce white QRS complete heart block. Any disease pertaining to the AV node, like a typical congenital complete heart block. This was a kid with 16 years old, if I believe. So she had a congenital complete heart block. So that obviously will expect the AV node to be diseased, and you will expect a narrow QRS escape rhythm. So what implies in terms of the conduction system pacing for understanding this AV nodal disease with a His bundle disease? So like here I said there is a disease in the AV node and the His bundle is disease free. So I'll be in a comfortable position to deliver the His bundle lead because the His bundle is completely disease free. So you will not have any disease in the His bundle because the HV interval, the normal HV interval is between 35 to 55 milliseconds. Here it is somewhere around 37 milliseconds. So it is normal. So that means that I can expect the whole length of His bundle to be disease free. On the other hand, if I see any white QRS morphology like this patient, surface ECG tells you that the patient has left bundle branch block. And when you go intracardiac, you can see the A and H. The AH interval is roughly around 80 milliseconds. But what about the HV interval? It's prolonged. It's almost like 85 milliseconds. That means that my His bundle is going to be diseased. So I'll have a tough time in identifying a good disease-free His bundle. And once I identify a good disease-free His bundle, which happened here, you can see here, this lower column is actually the lead electrogram. The advantage of connecting the lead to the EP system or to the programmer is that you can derive the electrogram and you can see in the lead, you can see the A wave and the H wave and the V wave, and the HV interval is normal. That means that my lead has bypassed the disease segment and I deployed the lead in an area where the His bundle was disease free, and this side, if I pace, I'll get a narrow QRS. This is just prior to screwing. I identified a site. Exactly.
You have normalized the HV.
Yeah.
Probably if you correct pace with slightly more amplitude, you might correct the LBBP.
Exactly. So almost like, yeah, so that was the Abbott sheet which was there before, where they had pacing electrodes at the distal end. So that was very helpful for doing His bundle pacing, where you have the distal electrode. So even before getting the lead in, you can just pace and see the site whether it is good or not. If it is not, then probably you can move up and down to get a good site. So that was
only for
His bundle.
For left bundle.
Yeah.
Improvised it.
Exactly.
Doesn't
So
have
only
trouble.
the Abbott people are very clever. They have taken the sheet back and they came out with a new sheet, which is very stiff and good for doing conduction system pacing. Yeah. So this is all about the left bundle, but when it comes to right bundle, majority of the patients will have a normal HV interval, but still you can see patients with prolonged HV interval in patients with conduction system disease. And these are the groups where if they have associated left ventricular dysfunction, you can do conduction system pacing and still you can improvise the ventricle. So when you see a combination of right bundle branch block, left ventricular dysfunction and prolonged HV interval, you can infer that there is something to do with the conduction system fibers. And when you rule out all other causes like ischemic cardiomyopathy, infiltrative cardiomyopathy, or some drug-induced or reversible form of viral myocarditis-induced cardiomyopathy, when you rule out all other things, then doing a conduction system pacing in this patient definitely will help. So this is all about.
This patient's left bundle, wouldn't you make it more right bundle? Or how do you correct the right bundle branch?
Yeah, so that is probably a troubleshooting the ECGs. That probably I'll cover up in the next session. Probably I may have to rush through in the next session because I think my time allotted is getting over. So I'll quickly move on to the last part of my talk about the implantation technique, probably which all of us are I think interested in. But getting the quadripolar catheter, it just takes 2 minutes to take the catheter right across the femoral vein to put it across the tricuspid leaflet, but it gives you so much information that it will tell you whether your His bundle pacing is going to work or not, whether it is all conduction system disease related, and it will give you a sweet spot on the fluoro screen that there is the His bundle. You go right below the His bundle to get it to the left bundles. Can I quickly get my third part, last part slides? Step by step implantation technique. So we have moved away from the horizontal pacing. We started with horizontal pacing in the year 2019, but when we later realized that, quickly I realized within 3 months that the leads were not stable. I had 2 patients who had come back with syncope, where I had implanted horizontal pacing for a complete heart block. So that quickly made me to realize that no, his model is not going to work for at least our population, where they want one-stop solution for all their disease. Whatever disease they have, they want only one medicine to cure all their diseases. That's really bad from our aspect. But still, yeah. So we have to learn something else to overcome this problem. So Dr. Wong in 2018, he has published his seminal paper on left bundle branch pacing, and we quickly adopted this technique in 2019. Now it is all left bundle pacing. I vaguely remember his bundle pacing being done in my lab probably 4 or 5 years back. Okay. So just ask a question. So if you have a scenario like this, so what will you do? Whether you will do this or will do this? Obviously, we all reimplant the limb back to the upper limb. So similarly, if you have a conduction system disease, where will you put the lead? You want to put the lead back in the conduction system, or you put the lead in the right ventricle? So logical answer is to put the lead back in the conduction system, so that you will be able to regenerate the normal appearing QRS and resynchronize the heart in a better way. So that is what we are doing, and that is what people were doing way back in 1970. This was the first ever paper on temporary horizontal pacing to correct the white QRS. Then subsequently we have learned the horizontal pacing and then left bundle pacing. So if you have EP lab, it's well and good. So it's always better to do the procedure with the EP lab. But if you don't have an EP lab, you can always use all other techniques. I've done patients with left bundle pacing with the TMT monitor, where it gives a good advantage of stopping it, increasing the sweep speed, and it allows us to take some measurements as well. So if you don't have EP system, you can use the PSA, which gives you the limb lead ECGs, or you can just get your 12 lead ECG system connected. The only modification which you have to do is get a pin type of ECG electrode, not that plug one, because plug one will mask your fluoro screen. Or even the TMT is good enough, where you will be able to increase the sweep speed as well. But don't do conduction system pacing without 12 lead ECG, because 12 lead ECG is must. It is 100% important for doing conduction system pacing. So tools for implantation. See, we are moving away from our conventional site. The conventional site is right ventricular apex. Here you want to drill the lead in the proximal interventricular septum deep to reach the LV subendocardium. So you need to have some accessory things. The accessory things are delivery catheters and not so-called specially designed leads. All these are adapted leads, but you need to have some leads which are easy for doing conduction system pacing. The most important thing is, of course, the delivery catheters. Like I said, the delivery catheters will take you only to the septum. It won't go into the right ventricular free wall. So that is probably the safety aspect when you are doing conduction system pacing. So the first and foremost thing is localize the horizontal. Just remember this picture. So this right anterior oblique picture, this is how cardiac conduction system fibers will be looking like. So you are having a his bundle and it goes down and divides as left bundle. When you track the his bundle in 0-degree plane, you have the right bundle. So when you are doing conduction system pacing, when you are doing left bundle pacing, it is our duty to not to injure the right bundle. Why? In patients with baseline left bundle branch block, yeah, so patient will develop on-table complete heart block. So this anatomy will tell you where to keep the sheath. So when you have a his catheter, when it acts as a landmark, you just have to take the sheath little below the his. But if you don't have a quadripolar catheter, nothing to worry. Put a TPA catheter right into the RV apex. You can see my right ventricular catheter going right into the RV apex, and this hump, the superior hump of this temporary pacing catheter will be roughly equivalent to the his bundle zone. So it's always better to take it, because it's our practice. Sometimes if you are in a hurry, we'll just put it in the RV inflow, and anyway it will capture the right ventricle, but that will not solve the purpose when you are doing CSP.
So the hump signifies the hinge point of the septal
Tricuspid, superior aspect of the tricuspid leaflet. So because it is going and just kissing that superior aspect, so that part will be corresponding. Probably you can equate it to his bundle. So you can see both are almost like correlating. You can see the distal his signal, distal his and the superior aspect of this catheter, both are almost in the nearly normal zone. So all you have to do is put a TPA catheter right into the RV apex. Just go 2 centimeter below that. The target area should be somewhere 2 centimeter towards the RV apex. It will be somewhere here to deploy the lead. So once you identify the target spot, then you confirm it by doing pace mapping. So you are still on the right side of the septum. Your pacing lead has to be just exposed. The pacing lead has two electrodes. One is the distal most one, cathode, and the proximal one, which is the anode. So here you will be just exposing the cathode out of the delivery catheter. So that means that we are going to pace in unipolar configuration. What does that unipolar mean? You will be using only one electrode. Bipolar, you will be using both the electrodes. But here, since our electrodes are inside the delivery catheter and we are going to expose only the cathode out of the delivery catheter, you have to do it in unipolar configuration. Just pace on the right side of the septum and see whether you are seeing a W pattern in lead V1, a discordant QRS complexes in AVR and AVL, and a predominantly positive QRS in lead 2. So these things, if you get on the right side of the interventricular septum, that tells you that that's probably an appropriate site to go for it. You know, Chinese are the people who simplifies the technique majority of the time, and it always helps us because they'll give a shortcut area to go in a better way. So this shortcut area helps for majority of the people. No EP catheter, no TPA catheter, go in RAO view, divide the right ventricle into 9 quadrants. If you want to do his bundle pacing, deploy the lead in zone 2. If you want to do left bundle pacing, deploy the lead in zone 5. But you need to orient in such a way that you expose the whole of the right ventricle. Right? That's very important. You cannot say it's probably in a 15-20 degree RAO. You have to go at least 25-30 degree RAO view. Expose the whole of the right ventricle and try to divide it into 9 segments, and that will be an easy way of doing it. And once you have done that, the next thing is to deploy the lead. Okay. So once the target site is identified, so you have to deploy the lead by giving rapid rotation. So what you are going to do is once the lead goes in, that W pattern will gradually ascend up to form an R wave, and you will have a simultaneous reduction in QRS morphology and duration, and ultimately once it reaches the left ventricular subendocardium where the left bundle fibers are, you will be able to see a QR pattern. Why QR pattern? We are pacing the left bundle, we are pre-exciting the left ventricle. So obviously when you pre-excite the left ventricle, the right ventricular activation will be delayed, and that will be reflected in the surface ECG as right bundle branch block morphology. So as you can see, I am giving rapid rotation. So the rapid rotations will usually elicit PVCs. In this picture you will be able to see. I am giving rapid rotation and the lead is moving rapidly into the septum, and this rapid movement of the lead will generate some premature ventricular complexes. So the patient had a baseline left bundle branch block. You can see the PVC morphology. Just track the lead V1. You can see the morphology changing from QS to QR pattern. So once you see the PVCs, you need to have a good friend of you to help you in finding out these PVCs, because you will be watching the fluoroscopy screen to give the rotation, and when your friend tells you that, yeah, you got this PVC of RBBP morphology, then probably you can stop giving rotation, and that is the ultimate endpoint for the procedure. So this way we call it as left bundle branch pacing guided by premature ventricular complexes approach. This takes hardly 5 seconds to deploy the lead. So when we calculated the time duration for that lead movement, it comes around some 5 to 8 seconds. That within that 5 to 8 seconds interval, the lead will traverse from the right side to the LV subendocardium, and with the help of the PVCs, you will be able to complete the procedure. There is yet another way of doing it. So if you are not able to give rapid rotation, with the probably in patients where we are doing with the stylet driven leads, you can connect the stylet to the pacing cable and do pacing. So that is almost the equivalent of what we just spoke about. So you have to see the lead V1 morphology. So as you drill the lead, the pace QRS morphology gradually changes from QS, and you can see some R waves started forming, and once you get a good R wave, you have to stop giving rotations. So probably this is an easy way of doing, because eliciting the rapid rotations and the PVCs will be a little difficult for the beginners. But this is all the conventional styler-driven leads where we have been using it for years together. All you have to do is you have to pace simultaneously and give rotation and see how the pace QRS morphology is looking like. So once you confirm that you are into this thing area, then we have to confirm that we are capturing the left bundle or not the LV septum. See, there are two important aspects of the LV side pacing. One is the left bundle pacing, and the left bundle fibers will not be sparse, will not be completely deployed over the left ventricular septum. There are some areas where the left bundle fibers will not be there. So there, if you are deploying the lead, it's all LV septal pacing. So you have to differentiate left bundle pacing from LV septal pacing. There are a lot of criteria, a lot of confusing criteria are available, but there is one thing which can be quickly done in your day-to-day practice. We know that the left bundle pacing is going to pre-excite the left ventricle, so QR pattern or RBBP delay pattern can be taken as a major criteria, and plus one minor criteria, what we call it as a LVAT or R wave peak time. So we will be measuring this R wave peak time in lead B6. Just quickly measure the duration between the pacing artifact to the peak of R wave in V6. Measure at 8 volt and measure at 2 volt. It should be short and constant both at high output and low output. So if you satisfy these criteria, that means that you have captured the left bundle. Remember, not all QR in lead B1 are left bundle branch pacing. Majority of the patients with septal pacing as well can have this so-called QR morphology, but this criteria, short and constant LVAT, will help you in confirming that you are capturing the left bundle, not the LV septum.
Yeah. 8 volt and 2 volt output are just to rule out a far field capture.
Exactly. So just imagine a scenario. Left bundle is like this, and my pacing lead is going like this. So if I'm here, still there is a considerable distance between the left bundle lead and the pacing lead and the left bundle. At 8 volt, because of high output, it will be capturing the left bundle as well. But when I reduce the output, the left bundle capture will be lost. So it's all septal pacing. So when it is a septal pacing, the lateral free wall activation will be delayed. So the LVAT will be prolonged. So that is the concept of doing this 8 volt and 2 volt. So when the lead is touching the left bundle, both at 8 volt and 2 volt, the LVAT will be constant. So this can be easily measured with the help of EP system or a PSA, or even if you don't have anything, just take a 12 lead ECG at 50 speed and see whether it is less than 2 small boxes. So less than 2 small boxes means it is 80 milliseconds. So both at 8 volt and 2 volt, if it is less than 2 small boxes, I think that's all is required for confirming left bundle branch pacing. So left bundle branch pacing, clinical implications. So for us, any ventricular pacing patient is dependent patient, we can offer them of this left bundle branch pacing technology. So be it a normal LV function or more commonly in patients with heart failure. So our idea of providing this resynchronization therapy is cost cut. So in non-ischemic cardiomyopathy, which is all the most common chunk of population coming for CRT, when they have a typical LBBP, you need just a dual chamber pacemaker. So I have implanted almost like 96% of patients with a non-ischemic cardiomyopathy with LBBP. Only they received a dual chamber pacemaker, and we just presented our data in last year's HRS as a late breaker, where we have shown that nearly 80% of them had normalization of the LV function. That is way superior when you compare it to biventricular therapy, because the normalization rate in biventricular therapy is close to 30-40%. Here 80%, and these patients, most of them are off drugs now. So I try to come down in medications. Ultimately, either a small dose of beta blocker or even without drugs, they'll be roaming around happily. Yeah.
Because CRT is basically non-physiological epicardial pacing, so it wouldn't normalize in most cases.
Exactly. So CRT, it's all like one side RV endocardium you are pacing, it's all muscle capture, and the other side you are pacing the LV epicardium. So again, it's going to be a muscle capture. Here it is like theoretically it is all like superior because you are going to produce electrical resynchronization.
This rotating fast is when if you rotate slowly,
PVCs will not come. So you need to generate some sort of fast rotation. So that fast rotation will irritate the myocardium to generate PVCs. Slow rotations will not produce PVCs.
So take the shots also from the sheet.
Yeah.
Where you will come to know how depth you are going on.
Yeah.
So
Good.
Another way is to take in it is short also. We have seen that. We have shown that Chinese wala. The RO came into the RB apex, take a good shot of 20 ml dye and see the negative shot of tricuspid bone. Just below to that over the septum, you will get a best idea.
Yeah.
If you do a skin angiogram,
Yeah.
you get a negative shadow of tricuspid valve. You really don't need to put a pigtail.
Yeah.
Yeah, I agree.
Putting a pigtail into the apex, you are actually going to make it more complicated. You are not going to get the best confused.
Yeah, no, he is talking about the RB angiogram which the Chinese have published for doing his bundle and left bundle pacing, where they basically did an angiogram to identify the tricuspid leaflet, and they marked the triangle, and the apex of the triangle will correspond to the distal end of the his bundle.
And the
So
base
that-
would be corresponding to the tricuspid.
Yeah, exactly. So that is for his bundle pacing. For left bundle pacing, so I try to avoid giving this contrast shot at all, because whatever you want to know about the depth of the lead can be inferred from the electrical parameters. Right? So when you pace and see the QRS morphology, that will exactly tell you where the lead is. Right? So when you have a good current of injury, that means that you are still within the septum. But when the paced QRS is QS, you are on the right side of the septum. When the paced QRS has started forming QR, you have almost crossed half of the septum. And with a good current of injury, with a good unipolar impedance, with a QR pattern, it's almost 100% sure that you are over the left bundle, and you don't have to give really the contrast. The problem of giving contrast is sometimes if you give forcefully, the septal muscle can get teared, and you have seen a lot of hematomas, a lot of septal venous sinusoids getting filled unnecessarily, which can be easily avoided.
So you have even perforated a septal vessel, means.
Yeah, I had a case
and
report,
published
yeah.
it.
Yeah, so that was a bad thing. So it happened during the implantation. The patient had an ST elevation. It was very high towards the close to the, yeah, exactly. So when you move closer to the his bundle, a lot of septal branches will be there, which might get injured. So that may produce ischemic injury. There are a lot of case reports of big septal hematomas. That's quite scary.
Sir, just one thing. When you don't have, if you want to go for a septal pacing, just probably I don't have an Agili sheath or probably other sheaths which are available, and I just wanted to put a single chamber, I will go for a septal pacing. So can you show those curves what we usually give? In a, can you just demonstrate it so
Sure.
that usually we can use at least not conduction system pacing, but when you are doing septal, we are getting close to those fibers.
Good. Yeah, so basically what I do is, so you can give both the RB curve as well as the septal curve in a single attempt with the same stylet, or more conveniently, you give a first as RB curvature, just take the stylet and just give a curvature towards you, so that will take the lead into the RB. So just deploy the lead inside the RB, put the lead inside the RB, take out the stylet out, and then give a curvature towards your left hand. That same stylet, turn it to distal end.
Curve is facing towards ourselves.
The curve should be like this,
Yeah.
and you will be tilting it towards your left hand.
Okay.
Left hand. Then put it in, it goes into the septum.
Okay.
Yeah.
Thank you so much.
Any other doubt?
How do you maintain perpendicularity when you are screwing?
Yeah.
Often we start at a good position while we are screwing slowly. That's the
Sheath comes
advantage
back.
that you have. You do it very fast. When people do it slowly, it starts deviating either.
Yeah. So
starts going tangential.
I always keep a second operator. So this sheath should be counterclockwise torqued, and this counterclockwise torque will give a good apposition inside the heart, and the sheath septal orientation is very, very important. When you have this 90-degree orientation with someone else helping you by rotating the sheath little bit counterclockwise, then it will be easy for you to deploy the lead.
Sir, few words on non-selective to selective capture.
So I specifically avoid discussing this, but this cartoon will explain you about this ECG QRS transition. See, basically, the pacing lead is deployed inside the septum, where there are two things. One is the muscle fiber, and the second one is the conduction system fiber. So basically, single lead is capturing two different substrates, which has two different electrical properties. Both are not having the same excitability. So one will conduct very fast but recover slow, the other will conduct really slow but recovers fast. So the excitability matters. So when you reduce the output from high to low, at one particular point, one of the substrate will lose its capture, so only one will be conducting down. For example, at 5 volt, both septal muscle fibers and the left bundle fibers are captured, so it will conduct down. But when you reduce the output, probably around one mode, the myocardium will lose the capture, so only the left bundle alone will be conducting. So in this case, it can be easily appreciated on the surface ECG as a change in QRS morphology, because previously two substrates were capturing, now only one substrate is capturing. So that change in QRS morphology occurs only if the lead was capturing two substrates. If the lead was not deep enough, it was just in the RV side of the septum, there are no muscle, this conduction system fibers, it's all only muscle. So as you reduce the output, the QRS morphology will not change. It happens only if the muscle pacing lead was capturing two substrates, one is the muscle fiber, other is the conduction system fibers. It can be either non-selective to selective or non-selective to septal, but when you show the QRS morphology change as you reduce the output, that gives you so much confidence that, yeah, you have captured the conduction system.
What if you have traversed the full septum? What will be the ECG finding?
Yeah, so septal perforations are one most important things. That's what when the previous question was asked, I was talking about the current of injury. So when you deploy the lead, the first thing you have to see is the current of injury. You have to ask your rep to show what is the current of injury. You should have a good ST segment elevation. When you are not seeing this ST segment elevation, that means that the lead has already perforated. You should never accept a parameter, however good the paced ECG morphology is, when you don't see the current of injury. So what you have to do is pull out the lead from that side and put it at a new site. When you just withdraw the lead little bit back, you will be able to see the current of injury again. Your pacing parameters will be beautiful. You will be able to generate a good QRS. But since you have created a through and through path, the lead will fall into the LV or come back to the RV on the next day. So it's always better to take it out and put it in the new site. The perforation incidence is very high. So I have reported an incidence of 14%. The Chinese, they have reported only 2%.
The bipolar assessment, at that time you get a negative current of injury when you perform.
Yeah, bipolar, I think.
Directionality, so that's why you get a loss of current of injury when you perforate.
Yeah, so whenever you are checking for current of injury, when you are doing this left bundle branch pacing, always see in unipolar configuration, because we want to know what is happening at the lead tip. When you see the bipolar configuration, this will average out between the cathode and the anode. Sometimes it may give you a false assurance that there is current of injury, but it may not be, because the lead is already perforated.
So it should be always in the sheath, some portion, the first marker.
No, it's not like that. It depends on the septum. The current of injury should be there when you see the electrogram. When it is not there, just pull it out and put it at a new site.
I think one more thing, sir, I just wanted to note. The lead number 3 is also should not be positive while doing all this thing. We can get all the parameters. We may come certain times the 3 is also getting positive, but we are somewhere into the RVOT, which may lead to temporads.
Yeah, so when all three are positive, be little more cautious. But one other important clue which we can get is, when you are in the RVOT, the AVR AVL will not be discarded. The AVR AVL discordancy will happen only with the parahesian zone, not in the RVOT. But when you, like you said, when you see all these 3 as positive, see whether you are capturing the RVOT.
Excuse me. Sometimes everything fits the picture. The problem comes is inserting the lead. Can you give us some tips regarding that?
Deploying the lead?
Deploying and screwing the lead.
Yeah, so there are 2 ways of deploying the lead. One is by interrupted rotation. Give rotation slowly, see the pace QRS morphology, see the pacing impedance, and then give further rotation. The second way is what I have shown, the rapid rotation. Rapid rotations are possible only if your hands are completely dry. The lead segment where you are going to hold the lead should be dry, and you should have a powdered hand. These are all the tips and tricks which I have learned in 2019 to give this rapid rotation technique. So what I do is I start with 2 powdered gloves and set everything ready, take the sheath into the target spot, take the lead into the target spot, and come to LAO, and once I am about to deploy the lead, I will remove my outer gloves so that I will be wearing a fresh powdered glove in my hand. That will give you enough grip over the lead so that you will be able to generate rapid rotation. And this rapid rotation should be with both the hands, and you need to know the septal thickness beforehand, because how deep you want to go, you should know. For example, if the septal thickness is 11 millimeter, the lead dimensions are such a way that the helix will be 1.8 millimeter and the inter-electrode distance is 9 millimeters. So all the way from the anode to the tip is around 10.8 millimeter. So go in LAO view and see the fluoroscopy view, give rapid rotation and see the movement of the lead. So once that anodal part touches the septum, then you have to stop giving rotation. For this rapid rotation, definitely you need to have a dry hand. For example, if your sheath is leaking, you'll have all the blood coming out of the sheath that will just make the area flimsy and you'll not be able to give that rapid rotation. So rotations closer to the sheath, dry hand, probably preferably both the hands, that will help.
One more thing. Do you tell your assistant to hold the sheath at the time when you're giving rotations, or you don't do it?
Yeah. So probably even the video you might have seen, the hub of the butterfly hub should be counterclockwise torque at 3 o'clock, 4 o'clock position, and they will be holding the sheath. You can see the second operator was actually holding it tightly, and you don't have to give a push, you just have to hold it without displacing it. Yeah.
Sir, can you repeat that length measurements, 0.8 and?
The helix is 1.8 millimeter, the helix is cathode, and the interelectrode distance between the helix and the anode is 9 millimeter. So it is like 10.8 millimeter. So in the radio, you can see this anode, the proximal radiopaque marker, the helix and the proximal radiopaque marker. The distal end of the proximal radiopaque marker and the end of the helix is 10.8 millimeter.
50% into the septum would be okay.
Yeah, it depends on the septal thickness. If you are doing it in a kids where the septal thickness is just 5 millimeter, 6 millimeter, then only 6 millimeter only will be going in.
W pattern. Sir, thank you so much. It was a very beautiful and excellent lecture. We have attended so many of, I think, workshops regarding the bundle pacing. But the insight what you have given right from the anatomy to the physiology and the techniques and the practicality what you have shown, and probably that Chinese things you have brought in into the easiest thing. I think we should give a big hand applaud. So he has given us such a beautiful. I think it's now almost 12 o'clock close, and this crowd I have seen in one of the first conferences that we are not enjoying some songs or probably some guitar shows. Probably this is one of the best workshops. Thank you once again, sir.
Thank you.